Welcome to Pharmacology Mini number 4, where we'll be talking about different types of pain medications. This includes non-opioid analgesics, opioid agonist, opioid antagonist, adjuvant pain options, and medications to treat migraines and local anesthesia. To start off with our non-opioid analgesics, these are medications that are used for anti-inflammation, fever control, and pain medication. We use it for mild to moderate pain, fever, dysmenorrhea, and some medications like aspirin in this category can protect against stroke and myocardial infarction. Selexicab can also protect against colorectal cancer. The mechanism of action for non-opioid analgesics is to inhibit cyclooxygenase. This includes both COX-1 and COX-2 receptor sites. COX-1 has decreased platelet aggregation and can cause kidney damage, whereas COX-2 decreases inflammation, fever, and pain and does not cause that change in platelet aggregation. First generations block both COX-1 and COX-2 and include examples like aspirin, ibuprofen, naproxen, indomethacin, diclofenac, ketorolac, and meloxicam. The second generation selectively blocks COX-2 inhibitors, and this is Selexicab. Side effects of these medications is increased risk for bleeding. So we would want to monitor for bleeding, bruising, sore throat. It can also cause GI discomfort and GI bleeds. So we would want to avoid use with alcohol because that'll increase the amount of ulceration and discomfort. And we would want to educate our patients to give with meals 8 ounces of water or milk. If it's severe enough, we can also provide them Protonix or Ranitidine to help control some of that GI discomfort. Adverse reactions is it can impair kidney function, which is evidenced by decreased urine output, fluid retention, increased creatinine and bun, and we would need to monitor their eyes and nose. With the exception of aspirin, all the other medications in this category can increase the risk of myocardial infarction and stroke, and so we would want to do a very low dose for those with cardiovascular disease. It can also cause salicylism, and this is tinnitus, sweating, headache, dizziness, and respiratory alkalosis. This is more common with use in aspirin, and if someone develops any of these symptoms, we would want them to stop taking the medication and notify their provider immediately. Then we have Reye syndrome, which is evidenced by confusion, swelling in the brain, and liver damage, and this is common in children that are taking aspirin while having a viral infection such as the flu or the chickenpox. And then lastly, we have aspirin toxicity. And this can be mild, or it could be to the same level as that salicystic emergency. This is a medical emergency, and the way that we would treat it is through activated charcoal, gastric lavage, or hemodialysis to get that medication out of the body. We would have to give frequent fluid hydration and electrolyte correction, and typically they're going to have a fever, so we would want to cool the patient down. Contraindications to taking these medications is if it's the first generation class, we cannot take it during pregnancy, if the individual has peptic ulcer disease or a bleeding disorder, if they have sensitivity to NSAIDs and aspirin, if they're children or adolescents with a viral illness. If they smoke, we would want to use caution, and we'd also want to use caution when prescribing it with ACE inhibitors or ARBs. Selexicab, the second generation, would not be able to be taken with individuals that have an allergy to sulfonamides or have a history of stroke or myocardial infarction. Specific medications that we want to keep in mind with contraindications is ketorolac cannot be given in patients with advanced kidney disease. Interactions that these medications have are with anticoagulants because they both cause bleeding, so we could see increased bleeding. Glucocorticoids can cause GI bleed, so that could also increase the risk for GI bleed. Ibuprofen and aspirin counteract the benefit in reducing the risk of a heart attack and stroke. Ketorolac and other NSAIDs increase the risk of adverse effects. And then supplements can also interact with these medications. So feverfew, garlic, and ginger can increase the bleeding, whereas ginkgo biloba can suppress coagulation. Nursing considerations is that we would want to monitor our patients for bleeding, GI discomfort, mental status, and pain. And we can administer these medications either PO or through IM and IV methods. If we are giving ibuprofen through an IV piggyback, it has to run over 30 minutes. If we're giving ketorolac, that's typically done through the IM or IV push method and then changed to oral after pain has started to kind of be controlled. And we would only want to give it over 5 days. As far as patient education goes, we'd want to instruct them to stop aspirin 1 week prior to procedure or expected childbirth, to take with food, water, or milk, and to not crush or chew any enteric-coated or extended release medications. In order to determine if these medications were effective, we would see reduced inflammation, reduced fever, pain relief, and absence of injury or adverse reactions. Then moving on to Tylenol. Tylenol is used to treat pain and fever by slowing prostaglandin production in the central nervous system. The side effects and adverse reactions to Tylenol include nausea, vomiting, and diarrhea. And the adverse effects are rare when we use at therapeutic range. So we want to make sure that they're within therapeutic range. This would be 4 grams over 24 hours in a healthy adult, 3 grams over 24 hours in a malnourished adult, and 2 grams over 24 hours in adults that consume more than 3 servings of alcohol daily. Typical adverse effects that we see is liver damage and toxicity. Mild symptoms of this would be nausea, vomiting, diarrhea, sweating, and abdominal discomfort, whereas severe symptoms would be hepatic failure, coma, and death. Contraindications for Tylenol is pregnancy and breastfeeding. It is a category B for oral or rectal administration and a category C for IV. We would not want to give it to patients that have hypersensitivity to acetaminophen, those that have liver or kidney disease, chronic alcohol use, or malnourishment. It does interact with alcohol and can increase liver damage. It also interacts with warfarin and can slow warfarin metabolism, leading to warfarin toxicity and bleeding. So we would need to monitor their PTT and INR, adjust their warfarin dose, and observe for any bleeding. Nursing considerations when administering acetaminophen is to monitor for pain, signs of liver toxicity, and interactions with other medications. If we administer it through PO methods, we would want to make sure that we monitor for the max daily dose, and we would want to educate them to look at all their medications to make sure that none of them also contain acetaminophen, because sometimes acetaminophen is added to medications and people don't know, then they take that with Tylenol and then they end up going over the max daily dose. If it's administered through IV piggyback, we typically see it in a glass container, and when it is in a glass container, we must open the tubing vent. We would not want adults to take it more than 10 days in a row and children more than 5 days in a row unless approved by their provider. An evaluation of effectiveness would be pain relief, reduction of fever, and no adverse reactions. Then we have our opioid agonist, and these are used to treat moderate to severe pain. The mechanism of action is that it alters the perception of pain and pain response by activating receptors in the CNS, and this can be the mu receptor or the kappa receptor. The mu receptor is going to be the primary effect, but it does cause pain relief, respiratory depression, euphoria, and sedation. When activating the mu receptor, it does tend to be more addictive and cause more physical dependence. The kappa receptors are used for pain relief, sedation, and GI motility, but often don't cause the euphoric or sedative effect. So if it's just activating the kappa receptor, then it typically won't have as much physical dependence. The purpose is to treat moderate to severe pain, induce sedation, reduce gastric motility for those that are having diarrhea, and it can also be used for soft cough suppression when codeine is added. Examples of this are going to be our Schedule II medications like morphine, fentanyl, meperidine, methadone, codeine, oxycodone, and hydromorphone or Dilaudid. The side effects include constipation, so we would want to educate our patients to increase their fluid intake, their fiber intake, and to possibly take with a laxative or stool softener. Orthostatic hypotension, so we would want to educate them to sit or lie down if they get dizzy or lightheaded. They may need assistance with ambulation and hydration. Urinary retention, so we would want to check for bladder distension and encourage our patients to void every 4 to 6 hours. Cough suppression, so we would need to assess the lungs and encourage occasional coughing and hydration. Sedation, so we would want to educate them to avoid driving or engaging in other hazardous activities when taking. and then nausea and vomiting. So we could encourage them to take it with an antiemetic or take with meals and fluids. Adverse reactions are respiratory depression. So this is a respiratory rate less than 12 breaths per minute, and it can be enhanced when taken with benzodiazepines, alcohol, or other CNS depressants. The treatment for respiratory depression related to this would be naloxone and resuscitation as needed. It can also cause biliary colic, which is mostly caused from morphine, and the treatment that we would do would be based on whatever treatment's recommended for that. We can also see opioid toxicity or overdose. So the triad of symptoms that we see with this would be comatose symptoms, respiratory depression, and pinpoint pupils. The treatment would be naloxone, mechanical ventilation, and monitoring of vital signs. Contraindications to taking these would be biliary tract surgery, pregnancy and birth. So it is a category C. We would not want pregnant women to take it because it can cause fetal dependence, and we would not want them taking it during birth because it can cause fetal respiratory depression. Also, we see kidney failure that would not be able to take this, and those with respiratory dysfunction. It does interact with CNS depressants, which cause an additive respiratory depression and sedation. Anticholinergic medications can increase constipation and urinary retention. Same thing with tricyclic antidepressants. MAOIs, or monoamine oxidase inhibitors, are a type of antidepressant, and when taken with it, it can cause hyperexic coma with seizures and respiratory depression. And then when taken with an antihypertensive, it can cause more hypotension. So nursing considerations would be to monitor their pain, vitals, and dosage. Sometimes you would need a witness to verify that you're giving the correct dose. It can be administered PO through IV push, which would be over 4 to 5 minutes, through IV piggyback, intramuscular injection, a PCA pump, and we often administer it either scheduled, PRN, or a combination of both. PRN is typically used for breakthrough pain, where scheduled is for pain control and pain prevention. Education would be not to stop these medications abruptly because it can cause withdrawal, and to take short-acting medications for breakthrough pain. Evaluation of effectiveness would be pain relief, cough suppression, resolution of diarrhea, and no adverse reactions. Then we have Butorphanol, also called Buprenorphine or Suboxone. This is an agonist antagonist. So it's an antagonist to mu receptors, but an agonist to the kappa receptors. So it does cause some pain relief with sedation, but it doesn't cause that euphoria, respiratory depression, and physical dependence. It is used for mild to moderate pain, opioid dependence, and labor. The side effects and adverse reactions would be, you may see some symptoms of withdrawal from the opioids, some sedation, some dizziness, and headaches. Contraindications would be a history of myocardial infarction, kidney and liver disease, respiratory depression, head injury, and opioid dependence. Interactions would be alcohol and CNS depressants, which causes an additive effect, and any opioid agonist. Administration is done sublingually. If needed, they can use naloxone as an antidote. We would want to monitor for vitals and opioid dependency. The education for Suboxone would be to not change the dosage without the provider's approval and monitor for feelings of hypotension. Then we have our opioid antagonists, and these bind and block opioid receptors to prevent the effect of opioids. So it's used for opioid abuse, reversing opioid toxicity or overdose, and to reverse severe opioid-caused constipation. Examples would be naloxone, which is administered IM, IV, subcutaneous, or nasally, and it cannot be administered PO because it has a high first-pass metabolism. Then we have naltrexone, which can be administered orally or IM, methyl naltrexone, which can be subcutaneous, or elvamopin, which is orally. Side effects would be tachycardia, tachypnea, and withdrawal symptoms. And contraindications would be to give it during pregnancy and breastfeeding because it is a category C, those with opioid dependency, hepatitis, and liver failure. Considerations is when administering, monitor for withdrawal symptoms, use proper administration routes. You may need to titrate the medications. You would want to monitor for tachycardia and tachypnea with rapid administration. And you do need to monitor respirations for 2 hours after administering. One thing that you would want to educate your patients if they're taking Alvimopan is to only take for 7 days, because longer than that, it can have a high risk for myocardial infarction. And then evaluation of effectiveness would be reversal of respiratory depression, which is evidenced by 12 to 20 breaths per minute, no shortness of breath, and regularity in breathing. We do see reduced euphoria and craving with alcohol dependence, and then no GI ileus or constipation. And then we have miscellaneous pain management. To start, we have migraine management. And migraine management is kind of a standalone type therapy because it requires both prophylactic and abortive therapy. Prophylactic means it prevents the migraines from developing, and abortive means it stops a migraine once it starts. For our first line or abortive therapy, we can use medications such as aspirin, naproxen, Tylenol, or triptans. This is sumatriptan, amitriptyline, aminotriptan, probitriptan, naratriptofan, and then zolatriptan. Our second line or prophylactic therapy would be ergotamine, dihydrogotamine, propranolol, divalproic or divalproic acid, which is also called Depakote, topiramate, which is also called Topamax, amitriptyline, estrogen, caffeine, isomethylene, and dichlorphenazone. When administering it, we want to make sure that we know the side effects and interactions of the medication, as well as any contraindications and interactions that we're using the combination of. As far as patient education goes, we want to educate them that abortive medication should only be used twice per week, that we need to identify any triggers that cause the migraines and avoid them. We would want to educate them on non-pharmacologic migraine therapy, like being in a cold, dark room or a quiet place, to ensure that they check their pulse before taking propranolol, to take their medications with food to reduce GI upset. If they're taking amitriptyline, to use extra skin and eye protection, and to avoid heavy machinery and driving if the medication causes sedation. Effectiveness of evidence of effectiveness would be reduced intensity and frequency of migraines, quick termination of migraines, and reduced dose and frequency needed to manage their migraines. Then we have our local anesthetics, and this is going to be lidocaine and ester type anesthetics and amide type anesthetics. The purpose and mechanism of action is to decrease pain by blocking pain impulse to that area. It can be used for dental procedures, minor surgical procedures, labor and delivery, and diagnostic procedures. It can be used regionally through a spinal or epidural, and it can be used topically for any skin or mucous membrane disorders, for endoscopies, IV insertion, injections in children, and wart removal. Evidence of effectiveness would be that the pain is relieved and that there's no pain during the procedure. The types of ways that we can administer it is through injection. This can cause vasoconstriction, or we would want to cause vasoconstriction to prevent the spread of that local anesthesia to other parts of the body. It can cause infection and gangrene. We would want to monitor their vital signs and mental status, and we would want to have emergency equipment prepared. As far as spinal and epidural nerve blocks go, we would want to monitor for hypotension, anaphylaxis, seizures, dura punctures, and respiratory depression. We can cause a hematoma or infection at the site if not done properly, so we would want to assess for that. If they do get a spinal block, we would want them to lie supine for 12 hours following the procedure to reduce severe headaches, and notify their provider if they're unable to void after 8 hours. And topically, we can apply it. We would want to assess the skin to make sure it's intact, and we would want to avoid wrapping or heating that area. Side effects would be CNS excitation, so it could cause seizures. If they do develop seizures, we can give them a benzodiazepine, and we would want to monitor for respiratory depression. It can also cause hypotension, cardiosuppression, so we would need to do an ECG. Allergic reactions, like antihistamines, can be used to treat that. And allergic reactions do happen more with the ester type than the amide type. It can cause prolonged labor and decreased contractions. It can cause fetal bradycardia or CNS depression. A spinal headache, like I said, you would want to lie for 12 hours after the procedure. and urinary retention. Contraindications would be pregnancy, those that have supraventricular dysrhythmias, heart blocks, liver disease, kidney disease, or we would want to make sure we're not using epinephrine in any areas with artery ends. So that would be like the ends of the fingers or the toes. Interactions would be with antihypertensive medications. Then we have our adjuvant pain medications. These are medications that enhance the pain response. So they're not necessarily pain medications, but they help pain medications to work better. Examples of this would be tricyclic antidepressants like amitriptyline and amitriptyline. These medications not only treat depression, but it can also be useful for fibromyalgia pain and neuropathic pain. Our anticonvulsants like carbamazepine and gabapentin and phenytoin. This can treat neuropathic pain and neuralgia. Our CNS stimulants like methylphenidate and dextromethamphetamine, and this augments pain control and reduces sedation. Antihistamines like hydroxyzine can treat nausea, vomiting, and reduce anxiety and insomnia. Glucocorticoids like dexamethasone and prednisone can increase appetite, treat pain from intracranial pressure, spinal cord compression, and rheumatoid arthritis. Bisphosphonates like etidronate and pamidronate can treat hypocalcemia and bone pain. And then NSAIDs like ibuprofen and ketorolac can treat inflammation and fever as well as dysmenorrhea. Interactions and contraindications for tricyclic antidepressants is it can cause orthostatic hypotension, sedation, and anticholinergic effects. Contraindications would be pregnancy, breastfeeding, seizure disorders, urinary retention, those with glaucoma or hyperthyroidism, or liver and kidney disease. It does interact with MAOIs, the monoamine oxidase inhibitors, which are antidepressants that interact with almost every medication, barbiturates, CNS depressants, antihistamines, sleep aids, alcohol, and St. John's worts, which is an herbal supplement that has serotonin in it. So when taken with a tricyclic antidepressant, it can increase the risk of serotonin syndrome. For anticonvulsants, it can cause bone marrow suppression, GI distress, drowsiness, rashes. It is contraindicated in pregnancy, breastfeeding, and interacts with oral contraceptives, and it can inactivate it. So if someone is taking an oral contraceptive, we would want to educate them to find another method of birth control. It interacts with warfarin, lithium, MAOIs, grapefruit juice, phenytoin, phenobarbital, CNS depressants, and alcohol. CNS stimulants can cause weight loss and insomnia. It is contraindicated in pregnancy and breastfeeding, hypertension and hypertensive crisis, Tourette's or those with tics, substance abuse, and it interacts with MAOIs, alkalizing medications, acidifying medications, insulin and oral antidiabetics, methylphenidate, and caffeine. Antihistamine medications can cause sedation, dry mouth, anticholinergic effects, and it's contraindicated in those with asthma, pregnancy in the first trimester, and breastfeeding. And though we would want to use extra caution in those that are in the second and third trimester, as well as in older adults. The interactions is with barbiturates, CNS depressants, and alcohol. Then for our glucocorticoids, it can cause adrenal insufficiency, osteoporosis, fluid imbalance, electrolyte disturbances, glucose intolerance, and peptic ulcerization. Contraindicated in pregnancy and breastfeeding, fungal infections, seizure disorders, and ulcerative colitis. It does interact with insulin, oral hypoglycemics, salicystates, digoxin, diuretics, and vaccines. Bisphosphonates can cause flu-like symptoms, abdominal cramping, esophagitis, diarrhea, venous irritation when injected, and hypocalcemia. It is contraindicated in pregnancy and breastfeeding, achalasia, esophageal strictures, and osteomalacia. Interactions is with calcium, iron supplements, and high calcium foods. And lastly, we have NSAIDs. The side effects of NSAIDs we've already talked about quite extensively during this lecture, and it includes bone marrow suppression, GI distress, and myocardial infarction and stroke, with the exception of aspirin. It is contraindicated in pregnancy, those with a history of bronchospasms, use of aspirin and other NSAIDs, kidney and liver disease, and it interacts with antihypertensives, aspirin, corticosteroids, alcohol, tobacco use, oral anticoagulants, and lithium. And that is the end of this pharmacology mini.